Okay, well, thank you. Stuart, Lewena is my name. I'm Director of Emergency at the Children's Hospital in Melbourne. And I'd like to just run through briefly what has been our experience through the winter of 2018. And it's been a very good winter from our perspective. We've approached this winter with an attempt to see how we can kind of adopt the holy grail of what all of us who live in Melbourne want to kind of do, and which is extend summer into winter. And in healthcare, that's as important as in our general life. And we have succeeded, I hope, from what I'll show, that a lot of what we enjoy in terms of good performance, good patient flow, good access that we achieve over summer, we've been able to introduce some strategies that has allowed that to extend further throughout the year. So, probably in reflection of some of the previous talks, and in no way disagreeing with the mantra that good patient flow doesn't start with the emergency department. It's very much a whole of hospital response, and it's a systems response. But we did look at the problems we were experiencing as a department and identified the fact, well, we're part of this whole hospital response, and we can't just be sitting back waiting for the rest of the hospital to fix issues that we identified needed fixing and they identified needed fixing. And whilst we've been very much advocating for and supporting that process throughout the hospital, we also identified the fact that there were some things that we could do in our backyard, things that we had total control over now, that could maybe contribute significantly to the flow and the access pressures that we felt within our department. And so I'd like to focus on two projects we've done, one very briefly and the second one which I'll focus on, which I think has really provided the bulk of our improvements we've seen this year. So it's looking at a flexible bed expansion model that occurs overnight, which is not a unique model and something which I know other health services have done, but we introduced it through this winter, and whilst the quantum effect of the amount of beds that we flex up was relatively modest, it's had a significant impact on how the emergency department functions. And then I want to spend most of the time looking at our front of house model of care and a little bit of the background about where that came from. So firstly, with regard to our bed flexing model for our short stay unit, similar to many emergency departments, approach winter with a bit of a sense of dread. And we know that winter demand is frequently going to exceed our overnight bed capacity. We have a particular problem in paediatrics where we know our inpatient length of stay is relatively shortened anyway. And so a large number of our patients who did require admission overnight, we were seeing were successfully able to be discharged the following morning. And yet they'd be patients who'd be spending maybe up to 18 hours in an emergency department bed, would complete all of their admission care within the emergency department and then be discharged. And we saw that that was a wasted opportunity to provide better care for those patients, and that if we could somehow provide some capacity at night to flex some bed capacity up to provide inpatient care for those patients in a more appropriate environment, that would also take the load and pressure off the emergency department. So with support of some winter funding through to the department, we implemented this winter the capacity to take what is our 8-bed emergency short stay unit, and each night at 7 p.m. flex that up to 12 beds. And it was a model of opening those beds up, knowing that they would close again at 7 a.m. the following morning. They provided some capacity for us to decant patients who would otherwise spend the entire night in our emergency department. And through that relatively small ability to really just decant 4 patients out of the emergency department, it has a significant impact on our access and flow. Because we may go from a department that might have 16 admitted patients blocking all but 4 of our bays to operate an emergency department for the remainder of the night. Release another 4 beds and you've got a 100% increase in your emergency department capacity for that night. We saw it was highly effective at kind of taking that relief, that pressure valve off the emergency department to let us keep on functioning. It also provided a better environment for those kids and their families to receive care. And it was shown to be safe and effective both for their care and for the department. So we functioned better. We started putting many patients through what is 8 short stay beds during the day and 12 at night. We're generating 34 separations per day through those beds. And importantly, we're not seeing a significant bounce back rate or complication rate or any adverse events or a need to on-refer to inpatient services. They're by and large being successfully managed in that model of care with the capacity to discharge by the following morning. So it's certainly something we look at operationalising, and it's now business as usual for our practice, and we plan to continue that ongoing. But the other really exciting thing that we did this year was looking at our front of house model of care. So the situation we had was we recognised that we would frequently have just as many, if not more, patients sitting in our waiting room as were within the rest of the emergency department combined. We were unable to clear space in our department, and that meant these patients were left sitting in our waiting room for often very extended periods of time. those long waiting times were contributing to the fact that they'd undergo unrecognised deterioration, which has been forefront, unfortunately, through several health services this year have experienced the ramifications of a child waiting in an unsupervised environment. That inefficiency and crowding just impacted further on the way the entire department, and I think by extension the rest of the hospital would function at that time. And it was certainly associated with poor patient and staff satisfaction and poor performance. So we thought about this and we appreciated the fact that we were maybe falling into some traps of wrong perspective on how we were doing this. I think we were as guilty as we were sometimes getting frustrated by some of our inpatient colleagues, where we would lament the fact that an admitted patient in emergency was maybe seen to be a little bit out of sight, out of mind. I think we were becoming equally guilty of patients in our waiting room being out of sight, out of mind. And it took a little bit of a frame shift of convincing all our staff that just because a patient is in our waiting room makes them no less needy or less important a patient for our department than if they're in a bed. So there was an agreement within the department that we were going to look at specifically deploying resources to the environments where there was demand and according to need. And that by doing this, we could hopefully initiate care earlier and make subsequent care easier. All of this was based around the fact that, yes, we wanted to improve performance, but we also wanted to make our waiting room a safer place and a more respectful place for people to be. And there was a little bit of selling to our staff in terms of why this was important. There was a little bit of resistance, thinking, I need to stay inside where all the sickest patients are, but the mentality of appreciating the fact, well, all those patients that were inside were in our waiting room earlier, they're equally important, and a patient in the waiting room is being disrespected if we just ignore them for that period. I use the analogy with some of our staff around the simple bread and water that you might get when you go to a restaurant, and that if you walk into a restaurant and you don't get served for an hour and you just sit there and you're ignored, versus this very simple measure of being served up a bowl of warm bed and some sparkling water, it's a totally different experience. And so what we aimed to deliver was a bit of bread and water for families while they're in the waiting room, and seeing if by doing that we could make their experience better, and ideally we could make our performance and the quality of care we provide better. So out of this, we devised what we call our rapid model of care. So rapid assessment, planning of the care they need, any investigations that may be relevant in a paediatric setting, and importantly think about discharge planning very early in the process. And many of our patients, we could start that discharge planning and implement discharge from the waiting room. For many others, it was really just about setting the expectations, highlighting what needed to happen, communicating that with families, but also with subsequent downstream care providers, so that we would start to think there and then about what it was that this patient needed, how do we get there, and how do we accelerate that process as best we can. I'd like to take the opportunity now to thank the fact that we did this as an unfunded kind of proof of concept trial in 2017. Out of some pretty modest results, we were successful in securing funding from the Royal Children's Hospital Foundation. So that's allowed us to run this as a trial this year. That's on the basis of this trial and the results that we very much hope that we can secure the funding to make this business as usual operations for future years. So what did we achieve? I'm just going to run through a few graphs that hopefully will show graphically that we did in fact achieve a continuation of summer performance through into winter. And whilst, so this graph is just showing our overall all patient treatment in time performance. Yes, we declined a little bit as the winter months hit, but we're certainly not to the extent that we had declined in previous winters. So looking at this year's performance compared to last year. And we also took longer until we started to see that decline. So winter in terms of those performance for us really didn't hit us until June, whereas in previous years it's been as early as March that we really start to suffer. If we looked at that cohort we are particularly worried about in terms of how this model of care can better identify kids at risk of deterioration and ensure they're getting timely access to care, we looked at our triage category 3 patients, which are really our high risk group with regard to that. Our category 1 and 2 patients always get good access to care and timely care, so that wasn't a concern, but we do know historically on previous winters, category 3 patients may wait what is very unacceptable periods of time before they initiate care. And we were really pleased to see that this model of care, whilst it was focused on waiting room care, it was having a flow-on effect to ensure that our sicker category patients were also receiving much more timely care. And so for the first time in my memory at the Children's Hospital in our emergency department, we have reached the category 3 treatment in time target for every month of this year. Whilst we looked at those graphs and figures and we were pretty impressed by the results, we also did a statistical control process looking at what is the mean performance of our treat in time over a period of 4 years? What is the range of performance, and what performance outside of that range really signifies something that's very unusual happening? And we mapped this out and saw that yes, in previous years, we get the occasional blip of unusual performance, and for us that's January, where we really just operate outside of our standard deviations of performance. But we saw that from February of this year, we jumped up into that high performance outside the range, the standard deviations of our normal mean, and we've maintained that performance throughout all of this year. So it was really good evidence to us that what we'd done was more than just appearing to be successful, but it was clearly statistically very successful. We've had a mean shift in terms of what our average performance is now, and we've shifted our control limits as well. It was all very good for us to think treatment in time is an important performance parameter, and it clearly is, but we also, ideally, if we saw this model was working well, wanted to see that also by treating in time, we're also treating more efficiently, and that by doing this, we were going to be shortening length of stay for patients and improving better 4-hour performance length of stay. So this graph is looking at our cohort of all patients and how we've achieved better discharge performance within that 4-hour target. And then if we look at that cohort where we are particularly in control of that performance, of those that we're able to discharge from the department, again, we saw that for the first year in my experience, we have achieved our 81% target for discharging patients within 4 hours for every month of the year. So it's something we've not achieved in the past, and we anticipate that if we can continue this process, it's something that we should be able to continue to achieve. Finally, the other metric that we were hoping we would achieve by doing this is previous winters we would see a very high and embarrassingly high rate of patients who would leave without being seen. They would come concerned about their child, they'd sit in a waiting room for a prolonged period of time, and they would leave. And by and large, that was a safe decision for those families, but we knew from previous experience that amongst that large cohort were a number of children who would come to harm by leaving without care. We've seen essentially a halving in our rate of patients who leave without care through the implementation of this model of care, and particularly importantly over that high winter demand period, we essentially treated 2,000 patients this year who we would historically not have treated. They would have come to our department left with no care, and that represents 2,000 patients who've received clearly much better quality of care, but it's also, in amongst those 2,000 patients, some significant risk that I think we've mitigated by doing this. And so really the highlights in summary, just summarising what I've gone through in those graphs. We've improved our treatment in time performance from 58 to 78% over our winter demand period. We've improved our category 3 treatment in time performance, so that cohort that we're particularly worried about, from 63 to 86%. Our completion of care in 4 hours has jumped from 68 to 76%. We've halved the proportion of patients who leave without being seen. And equally important to all of those performance metrics, we've got numerous examples now where we have escalated care of kids who would otherwise be spending time in our waiting room, and we've shown that we have identified children and through earlier escalation of care have prevented adverse outcome. And it's this that I think, whilst the metrics and the KPIs of our performance are clearly important to all of us who work in the department, and ideally those KPIs just reflect what is good and safe patient care, for many clinicians, it's an additional incentive for them to see that not only am I performing, and we are performing to achieve these better metrics, but we are doing this in such a way that is identifying the sickest of our patients and ensuring they get the care that they really require. And that has been a major carrot to our staff to say that, yes, this is more than just about improving percentage metrics. This is about delivering high quality care to kids in a waiting room and delivering why we did emergency medicine, which is identify those who are sickest and require our care. So our reality is we will continue to see winter days of 300 presentations, but we have through this year avoided 4 to 6 hour waiting times, waiting rooms with 30 to 40 families crowded in that space, and all of that contributing to this risk of large numbers of people leaving without care or long waiting times contributing to clinical deterioration. And so it's from this that, yeah, we're really hopeful that this model of care can just be ongoing. We've been very excited by its performance. Thank you.